Well, good morning, and can I welcome everyone to this, the 33rd and final meeting of the Public Audit Committee in 2024. Agenda item 1 is for members of the committee to decide whether or not to take agenda items 3 and 4 in private today. Is the committee content to do that? We are agreed. Thank you very much. Agenda item 2 is consideration of the Auditor General for Scotland and Accounts Commission joint report on alcohol and drug services. We took evidence from the Auditor General and his team a couple of weeks ago. This morning, I'm very pleased to welcome representatives from the Scottish Government, and we are joined by the Accountable Officer from the Health Department, Caroline Lamb, who's the Chief Executive NHS Scotland and Director General Health and Social Care. Caroline is joined this morning by Maggie Page, who's the head of the Drug Strategy Unit in the Scottish Government. You're very welcome this morning. And we're also joined by Scott Heald, who is the Director of Data and Innovation and Head for Profession Statistics at Public Health Scotland. So you're very welcome as well, Mr. Heald. We've got some questions to put to you, but before we get to those, I'm going to invite the Director General to make some opening remarks.
Thank you very much, Convener, and thank you for the opportunity to appear before the committee today. On the 31st of October, Audit Scotland published its report on alcohol and drug services, providing a thorough review of progress made and outlining key areas for further development. The Scottish Government welcomes this report, which captures the complexity of the drug and alcohol landscape in a clear and balanced manner. I sent a formal report to the Cross Committee on the Audit Scotland report earlier this month, outlining our planned actions under each recommendation, and that's been shared with the Public Audit Committee in advance of this session. Convener, in 2021, we launched the National Mission to reduce drug deaths and improve lives. Rooted in evidence-based interventions and with significant additional investment, the mission represents a unified effort with our partners to address Scotland's long-standing challenges with drugs and alcohol. During the first years of the National Mission, we focused on laying the foundations. We're now committed to building on those foundations and intensifying delivery, whilst also responding to new threats and challenges, such as the emergence of novel and stronger synthetic drugs and the concerning rise of cocaine in implicated harms and deaths. The Audit Scotland report acknowledges the progress achieved under the National Mission, particularly in improving national leadership, increasing residential rehabilitation capacities, and doubling the total investment in alcohol and drug services since 2014 and 15. Notably, this includes sustaining a record £112 million for alcohol and drug partnerships this year, as well as innovative initiatives such as piloting a safer drug consumption facility in Glasgow, which will open early in the new year, and our recently published Charter of Rights. However, it's clear that there is more to be done. Delivering whole system and preventative change is a priority, and wider Scottish Government activity is also supporting this. For example, through the recent publication of the Mental Health and Substance Use Protocol and the Prevention-Focused Population Health Framework, which will be published in early 2025. The report also highlights that greater attention must be given to alcohol-related harms alongside drug issues. We're already taking steps in this area, including working on a UK-wide basis to develop clinical guidelines for alcohol treatment and sustaining impactful measures like the minimum unit price for alcohol, which Public Health Scotland research has shown to be effective. The report underscores the need for a more sustainable transition plan beyond the National Mission's conclusion in 2026. We've begun to work with partners to ensure long-term strategies are managed smoothly through to the next Parliament. The ongoing independent evaluation of the National Mission will also help to ensure that these strategies are underpinned by robust evidence. Audit Scotland also highlighted the need for better cost effectiveness. Conducting this on a large-scale health programme has challenges. However, the evaluation will include an external study of how national mission funds have been allocated and spent, and information on the benefits which that expenditure has or is likely to have delivered. Convener, we're all aware that Scotland's drug and alcohol deaths remain too high, and we remain steadfast in our commitment to deliver change, guided by the evidence and the principle that every individual deserves the opportunity to live a healthier and more fulfilling life. I welcome your questions and the opportunity to elaborate further during this session. Thank you.
Thank you very much for that opening statement, which covers a lot of the ground that we will get into a bit more detail about in the next hour and a half. So can I, though, begin by asking the question I often pose on these occasions, which is whether or not you accept all of the recommendations which are contained in the Auditor General and Accounts Commission report?
Yes, thank you, Convener. We do accept the recommendations and we will find them very helpful in continuing to progress this work.
Thank you. Can I then just confirm a little bit more around that? Because when you referred to the letter that you sent us, which I think was dated the 10th of December, in which you are very clear in using the phrase quite often in the letter, the Scottish Government accepts this recommendation, the Scottish Government accepts this recommendation, which you use on in regard to nearly all of the recommendations, but there are two where you don't use that phrase. So can I just explore those a little bit more? First of all, in recommendation 1, which is the recommendation to work with key stakeholders to agree actions to address the lack of focus on and funding for tackling alcohol-related harm. Do you accept that there has been a loss of focus on alcohol-related harm?
So I think first thing I should say is that the Scottish Government remains absolutely committed to addressing alcohol harm, and that many of the actions that we've taken under the national mission have, by virtue of the fact that alcohol and drug partnerships are focused on both alcohol and drug-related harms, have actually impacted on those affected by alcohol abuse as well as other substance abuse. You know, there are many examples I could give you there around residential rehab, around workforce, around stigma, where the actions that we're taking are supportive of people both with alcohol and drug abuse issues. However, you know, it is clear that stakeholders feel that maybe there hasn't been the same level of focus that there has through the National Mission of Drugs. We continue to engage closely with stakeholders, and as part of the as an action coming out of the publication of our population health framework in 2025, we will be looking to work further with stakeholders to develop the detailed actions that will continue to progress that work on alcohol alongside the work on drugs. And I'm sure we can. There is more information I can give you if you want me to go into that now about how the work that we're doing around developing the national specification, etc., absolutely responds to concerns both about alcohol and drugs.
Yeah, I think other members of the committee will pick that up. But obviously you aren't a stakeholder, you're the accountable officer for the Scottish Government.
Absolutely.
And so I'm really asking you whether you accept a recommendation which points to the lack of focus on and funding for tackling alcohol-related harm. Do you accept that? So
what I've said is that I think a lot of what we're doing...
Do you accept that?
Yes, I do accept that, and that's why, as part of our response to the Population Health Plan that will be published in 2025, we will be looking at to set out specific actions.
OK, thank you. The other recommendation which is in this report, where there isn't that clear, the Scottish Government accepts this recommendation phrase, is in relation to a human rights-based approach to tackling alcohol and drug dependency and relying on the lived and living experience of people who are using services or maybe in some cases not able to access services. Do you accept that recommendation that there needs to be more of a focus on a rights-based approach?
Yes, absolutely. I mean, I think that the rights-based approach and absolutely embedding the experience of those with lived experience has been at the heart of all of the work that we've taken forward through the national mission, and I would absolutely expect that to continue.
And you mention in the letter, in relation to that, actually, the National Collaborative's Charter of Rights, which was due to be published on the 11th of December, this letter you sent was on the 10th. So did that, was that published?
Yes, that has been published.
It was. I don't know whether Maggie Page, you want to
no.
comment on that?
Yeah.
Yeah, so the Charter of Rights was published on the 11th. Both the First Minister and the Cabinet Secretary for Health and Social Care were there at the launch, and along with a number of other people and representatives from the United Nations as well. So absolutely, it was published and we fully support it.
Right, okay, thank you. We will have more questions around issues to do with the focus on alcohol-related harms and so on. But can I turn to the opening sections of the report that we've got before us this morning, which once again puts some focus on Scotland's performance when it comes to drug deaths. And in paragraph 2 of the report, it's cited that Scotland had a drug-induced death rate of 27.7 per 100,000 of population. And the next highest in Europe is 9.7 per 100,000. So that's almost 3 times the rate of drug deaths. What work is the government doing to understand why there is such a public health crisis with drug deaths in Scotland?
Yeah, I'll come to Maggie on this one, but I mean, maybe just in opening, I'll say that you know, those statistics are shocking, and it is very challenging to understand the differences between different countries in relation to socioeconomic factors, in relation to how things are, how data is collected, how things are counted. But notwithstanding any of that, absolutely, one of our key areas of focus has been on trying to understand some of the underlying reasons behind all that in order to inform the actions that we're taking. But I'll ask Maggie to give you a bit more detail on that.
Thank you. I'd absolutely endorse that. We're well aware that these numbers are unacceptably high. I mean, the national mission was announced back in January 2021 when those numbers first went above 1,000 a year. And so we're absolutely clear that these numbers are unacceptable, and our response has been this remarkable additional investment in addressing drug deaths. And you won't be surprised to hear that we're asked a lot, why is the numbers in Scotland so high? And the answer is essentially that it's very, very complicated and complex. And the academic community and the wider drug and alcohol community have, it's a source of a lot of debate, but there's a number of different drivers around this. So firstly, by and large, there's a report called the National Drug-Related Deaths Database that Public Health Scotland produce, and it tells you a lot about the background, not just what the toxicology is in relation to drug deaths, but also the circumstances of deaths and the background of the people who've died. And that shows us that about 3/4 of the people were using drugs for at least 10 years. Some of them were for over 2 decades. So this is a long-term, chronic problem that we're trying to address. And there is some research that points to an ageing cohort of people. So we're seeing the biggest rise in drug deaths among the people in their sort of from 35 to around 50. The average age of a drug death is now 45, and it goes up by about a year every year. So there's a cohort moving through the system who've been using drugs for a very long time and have been impacted by social policies and conditions over that period. And so there are some academics that point to that as a driver. There is mixed opinion on that as to whether that can account for everything. Poverty is another major driver. You'll see from the report that drug deaths are 15 times more likely in the most deprived compared to the least deprived areas. And that these sort of combined issues have had a particularly negative effect in Scotland, and particularly in the sort of post-industrial areas along the central belt of Scotland. But again, none of these fully explain everything. It's more, there's lots of multiple factors. And I think the third one I want to really talk about is the mix of drugs. So when we started to see a really big increase in drug deaths in Scotland, it started to escalate. You'll see from some of the charts from the drug death report from NRS that is followed alongside a huge increase in street benzodiazepines. So the emergence of illicitly produced benzodiazepines really impacted Scotland, and that's partly down to a culture where In Scotland, benzodiazepine use was more common than in the rest of the UK. Other drugs and drug use is a cultural phenomenon, and you'll see different patterns of drug use in different areas. So there was a bit of a perfect storm in terms of the emergence of street benzos becoming much more prevalent, accessible and cheaper, with alongside these other factors being particularly impactful in Scotland.
Yeah. And I think one of the things that's mentioned in the report, and I think Caroline Lammy, you mentioned it in your opening statement, is the increased incidence of drug harms related to cocaine. Yeah. I think rising from 6% to 41%, as documented in this report. I mean, is that something which is a Scottish phenomenon, or is that happening across the UK, across Europe? Do we know about that?
Again, I'll point to Maggie on this one.
Cocaine use is rising across Europe. It's becoming more prevalent and it's becoming cheaper across Europe. So it's something that we're seeing, and you can see that in the English and Welsh data as well.
But I mean, I don't know whether Mr. Heal has got a grasp on this or not. But so that figure of 41%, is that comparable to the kind of levels that we see in deindustrialised and poverty-ridden parts of South Wales or Northern England, or?
In terms of the instance of cocaine prevalence? For example. So I think one thing to point out with the drug deaths is almost all of them are polydrug use. So it's around 95%. I might be wrong on that. There's more than one drug implicated. So it's not one drug alone, it's the build-up of lots and lots of different drugs that people are using that is causing real particular harm. I can't tell you for sure what the percentage is for cocaine in the rest of the UK. One thing, we do have very, very detailed toxicology here in Scotland. Our surveillance systems are looked at as being much more advanced than other parts of the UK. And other areas are looking at modelling on things like we have like radar, which is our surveillance system. So I don't think it would be fully comparable to say exactly, percentage-wise in different areas. There's variations in pathology and toxicology across the rest of the UK as well. What we do know is the top line drug death, the comparable measure that's used, which is drug poisoning deaths, is accurate enough for us to say these are comparable. But once we get into the detail, it becomes a bit more challenging. But in terms of trends, cocaine is on the rise across the UK and Europe.
OK, and before I invite other members of the committee to come in, you mentioned drug poisoning being the index that allows you to compare across the UK, for example. But that tells us that the incidence of deaths is twice as high in Scotland as it is in other parts of the UK. I mean, and you say it's complicated, but surely it's your job to understand what the factors are and why Scotland is such an outlier. And if, as we said in the evidence session with the Auditor General, there is huge multiple deprivation in parts of the north of England, in South Wales, in Northern Ireland, and yet the figures in Scotland are so shocking.
Absolutely, and I've outlined it's complex, and there's a number of separate factors that are contributing to this. So there's no one thing I can say, this is why Scotland is so much worse. It's, there are a number of those factors, and as I say, there's, it's a source of a lot of debate and discussion. So I can't come to you and say it's absolutely this one thing that's made this issue, because that's not the case. It's far more complex than that.
OK, but I think Mr. Heal wants to come in. Yeah.
And just to echo and support the points Maggie's made about the complexity, I think one of the things to highlight is that this whole area is a big priority for Public Health Scotland, and Public Health Scotland are referenced throughout the Auditor General's report. I think one of the key things to highlight is that the availability of data that we've got in Scotland, we may talk more about data later.
We will, Mr. Heal, we will. Yeah.
Is strong relative to other countries. So actually, us being able to use that data to kind of drill down and understand what's happening is a powerful asset that we've got within this country. That can mean, though, because of the data that we've got, that seeking comparisons with other countries can be difficult, because they don't all have the same systems that we have in place in Scotland to kind of understand what's happening. Yeah,
but I think we all accept that there is a crisis here.
Yeah.
It's a public health crisis. that requires urgent action to address it. I'm going to invite other members of the committee to come in, and I'm going to start by asking Colin Beattie to put some questions to you. Colin.
Thank you, Convener. Just really carrying on from where the convener left off, I'm looking at the Alcohol Framework 2018, and I'm looking at the obstacles that have been encountered in delivering those commitments, and I'd appreciate maybe if it's addressed across three principal areas which are laid out actually in the Alcohol Framework. One is to reduce consumption, the other support positive attitudes and choices, and thirdly to support families and communities. What have been the obstacles there? And indeed, have there been achievements that we don't know about?
So I think the first major achievement we would point to is the introduction of the minimum unit pricing, and the fact that that's recently been confirmed through the Scottish Parliament. That minimum price has been increased, and maybe ask Scott to say something in a few moments about the evidence of the impact that policy has had. So I think that has been a success in Scotland. I think the other thing that we would point to, and the Public Health Scotland are undertaking some work at the moment around alcohol marketing, and we recognise that there are different views around that, which is why we're being very careful to gather the evidence. In relation to positive attitudes, Maggie will maybe talk a little bit about the work that we've been doing to tackle stigma, which extends across drugs and alcohol, and to enable people to actually come forward and seek help where they've got a problem, and as well a lot of the work that's been done to support families and to support young people in families affected by substance abuse, whether that be alcohol or drugs, I think has also been very helpful. Maggie, do you want to say anything on that first?
Yeah, I mean, in terms of the work around stigma, the work that we've been doing with the workforce, which is for both the drug and alcohol workforce, because the frontline services are often delivered together or delivered via EDPs, which cover both, are really tackling that. Stigma is a major part of the work that they're doing as well, in terms of tackling stigma within the workforce, but within that wider workforce as well, in terms of the other people within the public sector that people with drug and alcohol problems interact with on a very regular basis. Similarly, the National Collaborative, which is for both drug and alcohol, so it's substance use for people with substance use problems more generally, as well, is about taking that human rights-based approach. In terms of going back to the alcohol framework as well, the work around families that we're doing, so we have the whole family approach within treatment services, which is really about making sure families are involved and have that positive contribution that they can make to a loved one's recovery, and supporting them in the recovery on their terms as well. And just to point out that by family, and it's quite clear that we mean by family is not just immediate biological family, but also whoever that person considers to be their family and that their loved ones, that they all have an important role to play.
Just on the minimum unit pricing, so obviously the evaluation that Public Health Scotland undertook, I think, has been well trailed, and the conclusions of that report were that minimum unit pricing was having an impact in Scotland, and the report kind of contains details around the impact on mortality, hospital admissions and other factors that we can look to. And I think an important point was that the report highlighted that the 50 pence minimum unit price had stayed static for a number of years, and one of the key recommendations for consideration was to review the minimum unit price, so supportive of the fact that the Parliament made the decision to increase that in recent months.
In relation to drug taking, you were talking about the ageing nature of those that were dependent on drugs, and that many had been 10, 20 years in that particular situation. With alcohol, is there evidence that consumption among younger people is dropping? Are crude consumption levels an adequate indicator as to the harm that's being done? Do we have a similar situation where we have perhaps a fall-off among younger people, but those that have been dependent on alcohol for many years are still coming through the system and getting older. Does it track drug taking?
Maggie.
The sort of profile of people with alcohol problems is different from drug problems. So I said the average age of a drug death is around 45. For an alcohol death, it's considerably older. I can't remember off the top of my head, but I think it's around early 60s. So it's quite a different profile in terms of the progression of the dependency and the treatment and sort of the pathways that are appropriate in that regard. In terms of younger people's alcohol and drug use, there is sort of academically, there's been work done across the developed world really that shows that there has been a drop in substance use from younger people across the board. But what's concerning, I think, for a lot of people is that you may see this overall drop, but whether that's actually a sort of dividing between more people choosing to be abstinent, but actually some people, a smaller group of people, having really quite chronic problems. So it's that you can look at an overall drop, but not really understand how the degree to which people who will develop a problem will also drop in alignment with that. And that's what we also saw in terms of alcohol use. Scott may be able to keep me right on this, but during the pandemic is that we saw an overall, roughly a slight drop in overall consumption, but what it was is a real division between some people drinking an awful lot less and other people drinking a lot more, but overall that kind of averaged out. So we have to be careful when looking at those sort of top level measures to really understand the difference between manageable substance use, and I say substance use not just alcohol but manageable drug use as well, which is not necessarily a problem for that individual, and when it starts to become a problem for them and ultimately can be life-threatening. So there is that complexity that we can't really see now just because of what the patterns that are happening with young people, how that's going to present itself going forward. I don't know if you want to add to that.
No, just to say that was a good summary of the challenge with the statistics. I think one of the other key areas to highlight, or complexities to highlight with the alcohol data, is that sometimes the underlying conditions that arise from alcohol use can take many years to I guess, present themselves. And so I think it's just really, really important that the monitoring we do of the data kind of continues so that we kind of understand what's happening across the country. But all the things that Maggie said about that difference over the pandemic, and it may well be that some people were choosing to be abstinent, but others were taking more kind of averages out. So we need to be really careful in how we're interpreting the numbers.
I guess that takes us neatly into data collection, which is a problem that we always encounter with the public sector. And indeed, the Auditor General here comments on the lack of good data. How can we target the resources that we've got against this problem if we don't have the data that will inform us how to do it? So, for example, how limited is the data? Is it capable, for example, of being used to properly inform local service planning? And I'm thinking here of rural areas which are termed as hard to get to. And you've already highlighted the changing pattern of drug use. So it's not one particular drug of choice, it's moving in a different direction. So how do you use the limited data you've got effectively, and how accurate is it in informing you to deliver the services?
Okay, I'm going to come to Scott to give us the detail on this one, but first of all, I would say that it's obviously data is absolutely crucial in terms of the approach that we're taking, which is very much an evidence-based one. But I'd also maybe slightly challenge on, as I'm having limited data, and I'm sure Scott will want to challenge that in more detail than me, so I'll just hand to Scott.
Yeah, thank you. No, and there's maybe a number of aspects to this just to unpick, because I think what I would highlight is that actually Scotland as a country has good data. Now, there are gaps, and I'll come on to some of the gaps and kind of what we're doing to challenge that. And I think what's really important to recognise that there's more than one data source that we can use to kind of understand what's happening in this space. And so,
just sorry to interrupt, but just to be clear at this point, you disagree with the Auditor General's statement that there's a lack of good data?
So I'm going to say I disagree in part, because the Auditor General's comment is in particular about the Drug and Alcohol Information System, DAISY, and if I may, I'll come on to DAISY. But I think what's really important is to recognise that there's other data as well. So we've already cited the really good mortality data that we've got in Scotland. The kind of hospital data is strong and has been strong for many, many decades. So we've got really good data that we can use to get insights into what's happening. The other really important aspect we've got in Scotland is our ability to link data. So data from different sectors, but being able to link it to understand the pathways that particular individuals follow through, which is really, really important for understanding outcomes in terms of what happens to people with, in this case, alcohol and drug issues. Now, coming to the specific issue that the Auditor General highlighted, which was the DAISY system. So this is the Drug and Alcohol Information System, which was introduced in April 2021. And what the Auditor General has highlighted rightly is that there are gaps in that data, and I'll maybe come on to why the gaps exist and what we're doing about it, and kind of how we address those in terms of how we analyse and interpret the data. I think what's really, really important, though, is to understand why we introduced DAISY. So although there's gaps, DAISY actually as a tool in Scotland is really powerful and has the potential to be even more powerful. Because what happened before DAISY was that we had lots of disparate, often aggregate, so just kind of high-level summary data about particular aspects of an individual's journey through the system in terms of their treatment, which made it really difficult to understand kind of what the outcomes were for those individuals. So the ambition behind DAISY was to have a system at individual level that allows us to track individuals' progress through the system so we can understand what's happening. And because DAISY is at individual level, one of the advantages of that then is that we can also link it to the other data I've talked about, the hospital data and the death data, to really understand what's happening. So, and the other important aspect is, prior to DAISY, the data that we collected only covered drug misuse. So by introducing DAISY, we've also got a lot more data now on people who are presenting with alcohol problems than we had in the past. So although there's gaps, it's crucially important that we recognise the ambition behind DAISY is a good thing, and the data that we do collect can still be used. And I wanted just to come to the challenges that were highlighted in the Auditor General's report about DAISY. So I will acknowledge and accept there are gaps. And my role as the Director for Data in Public Health Scotland and as the Head of Profession for Statistics is that we need to have as robust data as we possibly can. And for the statistics, we need to have people having confidence and trust in what we produce. So that's at the heart of my role, and really important that we tackle it. Just to explain about DAISY, so DAISY itself collects data at different parts of an individual's journey through the system. So, for example, we collect data on referrals, on waiting times, assessment and reviews, through to the discharge from service. And the figures that are quoted in the Auditor General's report about completeness refer to completeness of the whole record of the individual. What it's not saying is that we don't have data for 34% of individuals. We do have some data for the majority of people, but there are gaps, particularly when it comes to the assessment and review part of it. And that is the work we're currently underdoing to address, and Maggie is chairing a review at the moment just to kind of get to the heart of that and to address it going forward. Now, just to explain kind of why the data gaps exist, and I think we've used the words a few times that it's quite complicated and complex, but the heart of it are two major issues. One is around individual consent to their data being used in this way. So this is a really highly sensitive data and highly sensitive for individuals. And individuals themselves are obviously coming into contact with professionals within the system. And those professionals need to kind of gain and build the trust of the individual they're working with to have the ultimate aim of improving the health of those individuals. If individuals choose not to consent to their data being submitted to DAISY, that is their right and their intent, and that can cause then challenges with the data coming through into Public Health Scotland. Now, in terms of that issue of missing data around consent, the biggest challenge for that is around the assessment and review data. Generally speaking, the data for referrals and waiting times is good, so we know how many people are coming into the system, so we can understand the profile of the patients, and understanding that profile of the patients allows us to understand where there might be gaps in the referral data, and then what we might do to estimate kind of the impact of that gap for policy making. The other issue, and I think you've touched on this, is kind of, I'm going to call it IT, child data sharing challenges. So what's important to understand is that the DAISY system itself is a data collection tool, and what we're aiming to do is to standardise across the country the same data coming through. So by having standardised data, we can understand what it's telling us across the country. Now, the ADPs between them use a combination of IT systems to record the data about their individuals who come through their services, and at the latest count it was 20+ different systems, and that's a challenge. So I'm putting that on the table, but the technology exists these days that we should still be able to get data out of those systems without mass standardisation across the country. But up till now, that's been one of the major challenges, kind of getting the data from those systems. And what we don't want to see happening is the ADPs using variable time double entering into their main system and then also into DAISY. That would be a waste of resource in the ADPs. So a kind of fundamental part of the review that we've undertaken is to work with the ADPs to make sure that we get that automatic transfer from their existing systems into DAISY. And our team in Public Health Scotland, working closely with government and the ADPs, are currently working with the ADPs to address that. And my own sense is that that will take time because it's quite complex. All these IT systems are different, so we have to factor that in. But I would expect to see real progress in the gaps that are mentioned in the report and the data over the next kind of 12 to 15 months. I'll maybe pause there quite a lot there.
Thank you for that background on the data. Coming back to what I asked before, how good is that data at informing local service planning?
Yeah.
And I'm thinking here, maybe particularly the case of the rural side, which is more difficult to reach. How good is that data to inform how you're developing local planning?
So, okay, let's start with that. So I guess for all the data that we kind of manage and collect in Public Health Scotland, there's obviously the national perspective we take, and that's an important part of what we do. But we also produce and make data available at local levels. So if you're familiar with our official statistics that go public, they're all often published at kind of ADP or health board level. One of the ambitions of the DAISY system, though, is that ability to be able to feed back to local systems about what the data is telling them. So in those areas where there's no relatively good completeness, the data is available. In the areas where the data is less complete, I would agree that that is more of a challenge. But it's also worth remembering that those same areas also have their own local data that they can use. What our ambition behind DAISY is that we've got that kind of common, consistent approach across the country that allows us to enable the comparisons across Scotland about what's happening and inform, obviously, future policy and direction.
I mean, my concern here is that there's a lot of money going into this.
Yeah.
There's a huge focus on it. And there's a high expectation, I think, across everybody in Parliament that there's results coming out of this. If the data is incomplete or doesn't give enough of a steer at a local level as to how patterns of drug use and the provision of the actual service to meet the needs locally, which must differ from urban areas to rural areas to different parts of the country. Are we getting enough information to be able to be sure that we're targeting the right place with the right resources?
So, are you going to start, Maggie? No, I'll go. So I think I'm going to say in short, yes, but there's still work to be done. Because as I've highlighted, there are a lot of really robust data sets that have existed for many, many years, which give us the granularity to understand what's happening in those local areas. And there are data sets like DAISY where further refinements and development is required. But we've highlighted kind of other innovative use of data within Scotland, like the radar. And forgive me, I always forget what radar stands for, but the kind of alert system around what's happening in different parts of the country. So that's kind of innovative and used in Scotland that allows us to highlight to particularly specific local areas kind of concerns that we've got that are arising. So I wouldn't want the committee to think that the gaps in data through DAISY are somehow limiting the use of data across the wider system. I think what we're acknowledging are there are gaps, we're addressing the gaps, but the ambition behind DAISY is to make it even better than what we've currently got, and we have to kind of hold firm to that.
Okay.
Yeah, if it's okay, just to add to that, I mean, I think Scott's absolutely right there. We do need to do a lot more work to bring things together to make them more efficient in terms of data collection, so that there's less of a burden on frontline services in terms of collecting and managing and processing data. We have national statistics which are, gold standard, and as we've said before, things like our radar surveillance system is considered, other parts of the UK and elsewhere are looking to that as a really good example of a rapid surveillance system. That's where we're using management information rather than your sort of gold standard national statistics. So you've got data coming in much more rapidly. You can respond more quickly to it. So you're offsetting your quality to your timeliness, because you can never have both at the same time in that kind of. But we also have, with regard to things like the medication-assisted treatment standards, through the MIST team that Public Health Scotland support, which is the implementation support team for the MAT standards. They are gathering a lot of data from local areas to support the implementation of those standards. And I think what we're working with, and where Public Health Scotland's expertise comes in, is that rigour of making sure that data is actually robust enough to be telling us, to be given to actually be useful and to not be misleading. And that's where we really rely on Public Health Scotland's expertise across the data to make those judgments, to make them in an informed way in terms of being able to interpret that data. But there's a real move now to being able to reduce the data burden by being more efficient and centralised with things like DAISY going forward. But at the local level, they do have a lot of data reporting through things like the MIST team, and also, as I mentioned before, the drug-related deaths database, which tells us all this detail about every death that's taken place in virtually all of the drug-related deaths across the country. So that tells us a lot about the background and the challenges that people are facing, which is a really, really valuable source of information in terms of developing strategy, both at the national and at the local level.
Okay, just a couple of quick questions to finish up. You've already indicated that comparisons with other countries, certainly from a data point of view, are difficult. But there must be lessons that we can learn from other countries. They must have had successes that we could, frankly, steal. I mean, we shouldn't be proud if there's someone's found a way to do something better. We should latch onto that and see if it'll work here. How good are we at learning those lessons?
So absolutely, I think, in every area we want to look to see what's happening, what's working well, whether that be in other parts of the UK, across Europe or internationally. And we do have engagement with other systems, but I'll ask Maggie around some of the detail on that.
Yeah, I'd absolutely agree with that. And I'll maybe just give a couple of examples. So for one, MAT Standard 1, so there's 10 MAT standards, so medication-assisted treatment standards. MAT Standard 1 is about having same-day prescribing. So when you present, particularly with an opiate dependency condition, you have that right where it's clinically appropriate to be prescribed on the same day. That comes very much from international evidence and from other countries which have seen, real improvement in treatment rates as a result of that. So that's one of the standards that we're working towards implementing throughout the country. And that's just one example of how we're taking that evidence-based approach, and that evidence is using that international evidence. Similarly, with our surveillance approach, we're very much connected in both with the rest of the UK and internationally, because obviously the drug trade routes are international, the trends, that's hugely valuable information. But also we hosted a roundtable at the start of this year where we had presentations from various different countries, including the Republic of Ireland, Canada, North America, where they were talking about how they are addressing, particularly when you're seeing sort of drug incidents where there's a major influx of a new or novel drug coming into the market, that and how that incident management approach, and that's very much informed and supported our own approach in that area.
Okay, but my final question here is really relating to early intervention, which in almost anything is a good thing. What progress has been made to moving into early intervention, preventative measures by way of education in schools? And how is the Scottish Government working with Education Scotland to take that forward?
So I'll kick on off on this one, but then come to Maggie around some of the specifics. So clearly prevention and early intervention is at the heart of what we're trying to do here. So we have been working with projects, particularly with young people, things like Planet Youth and the Roots programme, which are aimed at, in the first instance, around preventing people from getting into substance abuse positions, but also in the Roots work, working with children who are in families who are already affected by substance abuse and supporting them. I think I referenced earlier the work that we've been doing with COSLA on the Population Health Framework, which is due to be published early in 2025, and that is absolutely about looking at all the determinants that impact on population health, including the use of drugs and alcohol. So that's a whole government, in fact, a whole society approach to ensuring that people have good employment, good housing, good education, and good opportunities in a way that helps to ensure that they're able to keep themselves well and to have better life chances. And I've already referred to the framework being published and the work that we will be doing going forward from that. But in terms of the work with Education Scotland, Maggie, do you want to just come to some of the detail on that?
Yeah, I can do. I mean, I'd absolutely support that. The work around the whole population health framework is really, really important here. There was a literature review that was published a few years ago now called What Works in Drug and Alcohol Education. I think it's but essentially looking at the whole evidence around this area. And it's a huge report, but to summarise it in one sentence, it essentially says you need to take that holistic approach and look at building resilience in young people and making them make positive decisions, as opposed to the kind of, don't take drugs, kids kind of approach. So it's taking that holistic approach and seeing, a young person's decision to use drugs, particularly when they start to use drugs and alcohol very harmfully. There's a lot going on that gets a young person to that point. And it's, that we need to understand the drivers for it and address those and not just see the drug use in isolation. And that's really important. And that's why we've been working, across government and with the Population Health Framework as well around this. We are working with Education Scotland. We'll be meeting again with them early in the new year to take forward the specific recommendation from the Audit Scotland report, but they're already taking forward some work around this from our cross-government plan, which was our response to the Drug Death Task Force as well. So it's something that we are hoping to pick up further in the new year off the back of these recommendations. But I'd also just like to talk a bit about our whole family work as well. I know I've mentioned before the drug-related deaths database, and I do, although I don't mean to offend Public Health Scotland, but it can look like a bit of a dry statistical publication, but it's so rich in terms of the detail and the understanding of this challenge, and I'd urge people to read it. But one of the most striking statistics in that is that there was over 500 children under the age of 16 in 1 year that lost a parent to drug-related death, and it's not a particularly exceptional year. So we're looking at thousands of children who are experiencing this, and the intergenerational, multi-generational aspect of this challenge is really, really important. And that's why the whole family approach work and the Roots work, which Caroline already mentioned, which is around supporting those children specifically who are experiencing that, so parental drug use and parental alcohol use is really, really important, and actually really targeting those children rather. The whole education approach and the curriculum approach is important and absolutely has its place. But a lot of our energies and our focus right now is also on that whole family approach and working with whole families and those families most in need.
Thank you, Mayor.
Thank you very much. We've got a member of the committee, James Dornan, who's joining us via video link. So I'm now going to invite James to put some questions to you. Over to you, James.
Thank you very much, Convener. I'd like to ask some questions around the barriers to accessing services. Can you explain to me the reasons for the slow progress with the key national plans, including the specific actions to set out in the workforce and stigma action plans, such as the workforce mapping exercise and implementation of a stigma accreditation scheme and plans to address these.
Okay, thank you. Again, I'll come to Maggie for some detail on this, but you'll be aware that we published a Workforce Action Plan in December last year, and work has been ongoing to take forward the actions under that plan, a number of which I think at least one of them was listed in the letter that I sent to the committee in terms of that workforce framework being published early in 2025. We've also been working to ensure that there are routes into the workforce for people with lived experience, and particularly supporting an apprenticeship programme through that, and also working to ensure that there are guidelines for employers around supporting their workforce. So I think, you know, getting workforce, we have challenges around workforce planning and workforce data, and we're working on that as well. But getting the right workforce in place and supporting that workforce is key to the sustainability of this work, both through the national mission and beyond that. Equally, we've already touched on the work around stigma, and that needs to be an approach that runs through every aspect of what we're doing. But I'll ask Maggie if she wants to add any detail to that. Thank you.
Yeah, I'd agree with that in terms of the work around stigma. It really is. I mean, there's an outcomes framework for the national mission, and stigma is one of the cross-cutting themes, and it absolutely sits across everything that we do. And that includes work around the workforce framework, around the national collaborative, and obviously things like the implementation of the MAT standards. In terms of the workforce, I just add to what you've highlighted there that the workforce plan was developed with an expert delivery group, the WEDGE, and that group is continuing as well. And there's a real kind of co-production approach to that with experts in the field, and that those. You know, there's an awful lot of work that's happened over this last year, and we will be seeing early in the new year those three new publications and coming out of that. So the capability framework, which sets out the knowledge and skills expected of the workforce, try and upskill the workforce and give acknowledgement to the really important and special skills that people who are working in frontline drug and alcohol services have. Around pathways for people with lived and living experience to get into the workforce, and that includes volunteering opportunities and the value of volunteering as part of that pathway in some cases, and those guiding principles as well. And then, as Caroline mentioned, there's the addiction worker training programme as well, which Scottish Drugs Forum run, which provides I think it's SVQ level qualification that people can gain who've got lived and living experience to then go on to be addiction workers. It's a really inspiring programme. If you ever get the chance to go along to the graduation, I'd absolutely encourage you to do so.
Thank you very much for that offer. Do you agree, though, that there has been slow progress, or are you happy with the progress, or do you think that there has been slow progress, but you're now seeing an acceleration in progress?
I think what I said in my opening remarks is that a lot of the work has been about setting the foundations for this and making sure that it is informed by evidence, that it is informed by people with lived experience, and that therefore we're doing the right things and doing them in the right way. And we're now moving into that period of accelerated delivery. So I think, you know, that's where we are, and the focus has been very much on getting this right.
That's right then. Can I ask a question round about residential rehabilitation? Can you give us your understanding of the capacity and demand for this, and whether the service offers value for money?
Okay, so in terms of capacity, we set out an aim to provide 1,000 residential rehab placements a year. I think we're well on track to being able to evidence that we could deliver that, and we've increased. I'm going to hand to Maggie on the numbers, but we have also demonstrated success in increasing the number of residential placements that are available to us. But Maggie, do you want to pick up on the detail there?
Yeah, so we've set ourselves the milestone to get to 1,000 placements by 25-26, and there was a report published yesterday that shows that we've actually managed to surpass that already, but our ambition continues to increase placements even further, and the additional placement fund that was introduced this year will provide more funding so that even more people can be referred. So that, I mean, that to me shows a real shift in terms of how we've, the amount of progress that's happened around residential rehab from the starting point that we were at the start of the national mission. In terms of demand, our commitment is to try and increase the number of beds by 50%. And we have, I'm just checking the data here. So we've increased to... is
it to 500 and something from 45?
Yeah, so we're committing from 425 to 650 by 2026, and as of September there was a maximum capacity of 513 residential rehab beds in Scotland, so we're seeing progress there as well. Your question on value for money, I think it's there's that we produced at the start of the residential rehab programme of work, we did a lot of baseline working, because essentially when we started this area there was very little knowledge. The majority of residential rehab is either third sector or privately run. There's a couple of NHS providers, and our investment has largely gone into that third sector area. There's around 20 providers in Scotland now, and they're all quite different as well. So it's when we talk about value for money, I think the challenge is that people will compare it to, say, a pharmaceutical intervention like methadone, for example, where you've got a much more standardised approach to understanding cost and value for money because of the scale and the standardisation approach that you can take. If it's a pharmaceutical intervention, you go through NICE trials and all of those sort of things. With residential rehab, it's a psychosocial approach, and you cannot do the same kind of comparative work. It's just not possible to do it in that way with this type of approach. The baseline the baseline data that we gathered showed the costs of residential rehab and the various different costs for different providers. And by and large, I think the average cost of a placement is around £20,000. And, that's... So I think it's useful to know then in terms of when you're doing your maths and working out how much it costs to get those to people into residential rehab. And I think I would argue that we are seeing results of that, and it's the fact that we're getting more and more people into residential rehab and that people are asking for it is really important.
Can I just come back to the value for money? But then, I mean, and I agree. I think that residential rehab is vitally important, but there must have been some work done. There must surely be some way to gauge if this is a more cost-effective way as well as a successful way to treat people who need that kind of input than medication or the other routes that you go down, because there must surely have been some work done beforehand.
Yeah, there's been a lot of work done. As I say, that a lot of we invested a lot of analytical work into the sort of baseline work around residential rehab because we were starting from such a low base with the sector being quite underdeveloped in Scotland at that stage. And there's been a lot of work. As it is very challenging to look at value for money. I'm talking from an analytical perspective here, to look at the exact value for money and to compare it with a medical intervention like methadone, because simply because you're comparing apples and pears from that analytical perspective. So. There's methodological challenges, but having said that, we've commissioned Public Health Scotland to undertake an evaluation of the residential rehab programme specifically as part, and that fits into their overarching evaluation of the national mission as a whole, and that is looking at value for money, and because we recognise not only that we looked at the evidence base of what was out there at the start, but also by our major intervention by making a significant investment in both the capacity and in referrals in residential rehab as a result of the mission. We have a duty to also follow that through and add to the evidence base as we go as well. So they're developing a core minimum data set. So the publication I referred to that was published yesterday or Tuesday everything's on a Tuesday with Public Health Scotland. So the publication that was published on Tuesday was the first publication from that core minimum data set. So at the moment, it doesn't tell you a huge amount. It tells you about numbers of referrals, but that will build as we go. And it's that minimum data set that we'll be able to collect and hopefully be able to track some people going through residential rehab and contribute to that evidence base. It's always a real challenge, I think, in health. Is some things are easier to measure than others. Doesn't mean to say that they're more effective or more important, and I think that's where we have to be quite brave and but also follow the evidence and add to the evidence base as we go.
Okay, right, thank you. I've got one last question. Could you give me an assessment of the size and scale of recovery communities and if adequate measures are in place for safeguarding the welfare of volunteers and those with lived and living experience who play a key role in recovery communities?
Okay, thanks. I'm also going to come to Maggie on this one, but yeah, clearly recovery communities are really important, and another area that we've been seeking to support and promote throughout the mission. But Maggie, do you want to answer the specifics?
On the specifics, I don't have to hand the actual data on the size and scale of recovery communities. I do know that we are supporting recovery communities. We support them through the Scottish Recovery Consortium, which is the sort of national body for recovery communities, and they have reported that there has been a growth in recovery communities, either in the sizes of individual ones, but also in the numbers of them as well. But no, I don't have the exact data, but I'm sure we can provide that for you in writing. And again, SRCs, so its Recovery Consortium, play a really important role in being the voice for recovery communities, but also supporting them in terms of issues around safeguarding and that kind of sort of leadership around that area as well.
Okay, well, listen, it'd be helpful if you could get that information to us when you can.
We will do.
Right. Thank you, Convener.
Okay, thank you. Can I just pick up on one thing, Maggie Page, which you said that the residential rehab sector was underdeveloped, and you were painting a picture as though this is kind of year zero. Isn't it the case that there was a much greater level of capacity before, but there was a contraction? And what we're seeing now is an expansion on the back of a former period where a lot of these places were being reduced.
I don't really recognise that. I'll have to check. I mean, we did the baselining report to really just look at what was out there, because there wasn't a central investment into residential rehab, so there was no kind of central record of the number of residential rehabs out there. So there was a lot of work done at that stage to understand what provision was. I was quite involved in that report at the time, and what some of that was telling us as well is that a lot of these residential rehabs, particularly the private ones, they existed, but they were almost exclusively private and quite often had an international clientele. So although they were based in Scotland, they weren't necessarily part of that Scottish landscape of provision. So, I mean, I can get back on writing, but that's not something I recognise, that it was contracted over the shorter term anyway. It depends what period we're talking about. Yeah, maybe I'm talking about a slightly longer time horizon, but I know in discussions I've had over the last few years that's been something which has been raised with me. But anyway, we need to move on, and I'm very happy to invite Graham Simpson to put some questions to you. Graham.
Well, thanks very much, Convener, and good morning to you all. It's been a really interesting session so far. I just want to pick up on a few things that have come up already, and if I could stick to the residential rehab, because the Auditor General says in his report on page 33 of his report that there are barriers for people accessing residential rehab. He says, I can quote from the report, many people are identified as unsuitable for it because they have mental health issues. There are no local facilities, or for whom moving family and children would be impractical. They're not ready to cope with the high intensity of a residential programme. They're not able to meet the requirements of an abstinence-based approach. So, given that he was quite clear about this, do you think that people who need residential rehab are missing out on it?
I guess just an introduction to that, I would say that I think that, you know, residential rehab will not be suitable for everybody, so it's not the only answer. So what we need to ensure is that there are services that are available that respond to people who are ready for abstinence, just as well, to take one example, just as much as those who maybe are not yet ready to take that step. But I'll ask Maggie to come to the detail.
Yeah, I would agree with that. And I think just looking at the points that you've highlighted there from the report, they're largely correct in that our aim is that residential rehab will be available for everyone for whom it's deemed clinically appropriate. And that is really important, that it is clinically appropriate for them, because it can be a high-risk path for people if they are not ready for residential rehab. Taking that abstinence-based approach can have a high risk of relapse, or for that placement just not to work for them. And that you know, if they drop out of that can psychologically be really, really stressful for somebody. So there has to be, you know, close clinical involvement in that discussion about what, you know, what's appropriate for that individual at that time as well. And I mean, the other points, just to pick up on them, so that kind of covers that point of whether they meet the requirements. And the requirements is the clinical appropriateness. It's you know, important to highlight that, and that being psychologically ready and for them to be in the place that they want to go. So that it's not the silver bullet that I think some people, you know, in some of the discourse it's presented to be. And we should certainly not be compelling people or forcing people into any residential treatment. And that would never be the intention. But just going back to the other points there, saying that there's no local facilities for whom moving family and children would be impractical. Yes, we accept that, but we also have introduced and funded there's 2 new mother and baby units supported through Aberlour that have now been introduced in Scotland, and there's also Harper House, which is the whole sort of family unit as well. So these are new interventions to try and widen the accessibility of residential rehab for lots of different people with lots of different needs. And then going to that first point around mental health issues, that's something that is a much wider challenge that we're very aware of and been taking actions to address. So we've just recently published a protocol for mental health and substance use, because we know, you know, that people are telling us, and that, you know, the evidence suggests people, you know, they can't get their drug treatment because they've got a mental health condition, or they can't get their mental health treatment because they're considered they have to sort out the drug condition. And that protocol is setting that gold standard for how the 2 services should work together at the local level. And his Healthcare Improvement Scotland have been developing that on our behalf, and are seeing that being rolled out across the country. And that's a really important point, not just for residential rehab, but for drug treatment and mental health treatment more generally.
But do you think, I mean, I accept what you say, that, you know, not everyone is suitable for it, and it's not a silver bullet. Mm-hmm. That is true. But I think my basic point was, are there people, you know, are these barriers too high in some cases? So are there people who are missing out, who might actually be suitable, and they're missing out because of the strict criteria?
Well, strict criteria. This is a clinical assessment as to whether somebody is whether the treatment is clinically appropriate for somebody. I think what's important is that we ensure that where residential rehabilitation might not be clinically appropriate for someone, that there are other routes available for them.
Yeah, I think that's absolutely right. And as I just reference again the evaluation that Public Health Scotland are taking on, are carrying out on the residential rehab programme specifically, which will be going into these questions in a bit more detail as well. And as we're taking that kind of learn as we go approach.
Okay. I'll ask about another area. Colin Beattie raised the point about younger people. I think this is anecdotally, we read that younger people are not perhaps drinking as much as their parents did. I can testify to that. But you know, we've read various reports that is the case. You'll get younger people now who just don't drink at all. Have you got any data on that in Scotland? Because if that is the case, then that would suggest that at some point the alcohol problems that we've got are going to lessen.
Scott.
Maybe starting, and Maggie might want to come in. So I guess there's it goes back to that it's quite complicated. So I think anecdotally what you outline is correct. I think the challenge we highlighted before, though, about there'll be people who choose abstinence, so don't drink, and there'll be people who are drinking excessively, and that's the area we need to just kind of understand about, and it's those individuals then that might have the further impact on the system at a later date. So I think, you know, it's really important that we get beneath that data. I don't have the figures to hand unless Maggie has more details she can shed today.
I don't have the figures to hand either in front of me.
Do they exist?
I think they do. I know we certainly have been tracking that.
Okay.
I'm not sure how recent the statistics are in Scotland, but it's something that we definitely track.
It just strikes me that it would be interesting to find out, I think, that why that has happened, because there does seem to be a shift.
Yeah,
and it would be good to understand. Mm-hmm. I'm sure it's complicated, but it would be good to understand what has led to that shift. And if there's anything we can learn from that.
I think we could come back in writing with some more detail on that, because I know it is a sort of a lot of academic debate, because as I mentioned before, it's actually a Europe-wide phenomenon that there's been a sort of cultural shift away from heavy drinking for drinking generally for young people. Okay. So, yeah, it's like anything when there's a source of academic debate, it becomes complicated and there's never one straightforward answer. But I think that, you know, there are good points there in that, you know, if there's less drinking overall and that becomes a generational shift that we move through, that can't be a bad thing. But I'd also highlight that we do need to make sure that we understand what's happening underneath that, and if there are still a cohort of people who are drinking to excess, that can actually become even more isolating for that cohort as well. So we have to probably change our approach, but not saying it's a good thing or bad thing, but we would need to really be very mindful of that going forward.
Echo that, I can certainly follow up. We have a kind of team in Public Health Scotland dedicated to looking at alcohol misuse, so I can certainly take that back and work with Maggie to come back with a briefing.
Okay, that'd be great. And just one other thing, just from picking up on what's been said already, Maggie, you said that street benzos are more prevalent, or were more prevalent in Scotland than elsewhere. Do we have any idea why that is or was the case? So, essentially, prior to the emergence of street benzodiazepines, what was common was the misuse of prescribable benzodiazepines. So, temazepam, blues, jellies, you may have heard them referred to as various different things over the years. So temazepam and diazepam, the two main prescribable ones, were very commonly misused in Scotland, and that was just a cultural thing, whereas crack cocaine was more commonly used in the southeast of England, for example. And, you know, it's just one of the points, one of the sort of drivers, and I'm not saying it's absolutely, you know, the driver, as I mentioned, it's complex, is that Valium or temazepam or jellies or whatever you want to call them were more common and just more part of the drug use culture up here in Scotland. So with the emergence of these stronger, cheaper, more prevalent street benzodiazepines, which, you know, are, you know, we've seen drug seizures in Scotland of these in the millions in recent years, it just meant that, you know, that the Scottish population was more vulnerable to that than the rest of the UK. Okay, I'm going to move on. The national mission is due to end in 2026. Can you tell us what the national mission is and what has it achieved?
Yes, so the National Mission set out to address the public health emergency around drugs, and I think, as we've already described, that has had a positive impact in relation to a lot of the work that's been done around alcohol. It's been very much, I think, in the early phases around setting the foundations. We are now moving into sustained delivery, and from there we will transition into the post-national mission, and a lot of the work that's been done around the workforce, around some of the national guidelines, around the development of the national specifications for drugs and alcohol services is absolutely about putting all of this work onto a sustainable footing for sustained delivery going forwards, and that will be supported by the evaluation that Public Health Scotland are doing. We have reported regularly on the progress of the national mission, but Maggie, do you want to add to that?
Yeah, I can add to that. So essentially what the national mission is a mission to reduce deaths and improve lives, and I think that's really important, that it's for both. It's, you know, we're responding to the drug death crisis and the unacceptable levels of deaths, but recognising that that alone is not going to address this problem, that we actually need to improve the lives and support people who use drugs and their families and the communities that they live in. So it's just to emphasise that there's that dual purpose, and that means it's difficult in a way when we go on to what is it achieved, because obviously we are, and rightfully so, judged on that overall top line figure of drug deaths, which we saw a peak in 2021. 2022 we did see a significant drop, and unfortunately that drop wasn't sustained in 2023, so we saw a 21% drop and then a 12% increase. What we're seeing going forward, and we just recently had the suspected drug deaths published, which saw around a 7% decrease on the first 3 quarters of 2024 compared to 2023. So I think I might have just got my numbers, my dates, the years muddled up. So for the record, for the official report, I just acknowledge that. But we're now seeing, hopefully, you know, that we're not seeing that increase continue, and it does look like it's coming down in the region of around 7% for this year. But that, you know, we'll have to wait and see what the official statistics say. But I think my point here is that the national mission isn't just about the deaths, but it's about improving lives, and that is a much more challenging thing in terms of measuring and evaluating what it's achieved. But it's also very, very important that we do that, and that's why we've had Public Health Scotland do the full evaluation of the national mission and ask those evaluative questions, and they're doing a lot of work around understanding that. So they've done key informant interviews. They did a workforce survey that was published a few months ago. They're doing a survey of lived and living experience as well, to really understand from people, you know, directly involved in the national mission or directly being supported by the national mission, what their perspectives are.
Okay, I mean, my reading of this is it's all very well to have this mission, but given the figures that we've already discussed, it's not been a roaring success so far. That's just my view. I want to move on to discuss the link between poverty and drug deaths, because that's quite clear. In 2021, the National Records of Scotland made clear the link between the two, and they produced a report. It stated that in 2020, after adjusting for age, people in the most deprived areas were 18 times as likely to have a drug-related death as those in the least deprived areas. That ratio, this is still quoting from the report, has almost doubled in 20 years. In the early 2000s, those in the most deprived areas were around 10 times as likely to have a drug-related death as those in the least deprived areas. So I think things have got worse, really. Why do you think things have got worse?
So I'd start off by saying that absolutely that link between poverty and both drug and alcohol abuse, and therefore drug and alcohol related deaths, I think is well understood, and is I think the links between poverty and population health more generally are absolutely, as I described earlier, challenging those are not just a cross-government mission in the way that we've approached the drugs mission in the response to the Drugs Task Force report, but a cross-society mission as well. I think that probably some of the statistics that Maggie quoted earlier about the long-enduring nature of drug use and the impact that that has had, so having its roots in poverty, but then the impact of people who continue to use drugs for long periods of time has also had an impact there. But Maggie, do you want to add to that?
Yeah, I mean, I think you're right. This is a problem which is a national problem, but is particularly acute in the most impoverished areas, and that we absolutely recognise that in the work that we're doing. And also, while that ratio is doubled, that is with that at the same time as that increase. So this increase has really negatively affected those poorest areas most. And that's why we have been taking this cross-government approach with the national mission. So our response to the Drug Death Task Force report was a cross-government delivery plan, which had over 80 actions that we're committed to and that we are tracking as we go and working really closely. So we have a unit within the Drug Policy Division in government, which is the whole systems unit, and they work really closely with people across government. So with mental health, with the protocol that I mentioned earlier, with colleagues that work in homelessness, with justice services, and other areas as well, to make those links and make sure that we are delivering on that whole systems. And that other areas, I do spend a lot of my time presenting and talking to people about the national mission to other parts of government and other parts of public policy generally, to kind of emphasise the needs of people who use drugs, because the people who use drugs are also people who use lots of other services and need lots of other services and support as well. And they shouldn't be looked at as a drug problem. They're a person with a multitude of challenges and needs that we need to address. And that is the approach that we're absolutely taking. Okay.
I didn't want to leave the Auditor General out of this. I'll just quote from his report. In 2022-2023, people in the most deprived areas of Scotland were 7 times more likely to be admitted to hospital for an alcohol-related condition than those in the least deprived areas. I think we're all agreed on that. But it just strikes me that, really, the NHS and the alcohol and drug partnerships are picking up the pieces for a failure to improve the general wealth of the nation. If poverty it's embedded in some communities and it's not getting any better, it's you guys that are picking up the pieces. So I was concerned to read in the Auditor General's report that there'd been an 8% decrease in real terms funding for ADPs over 2 years. I mean, why was that, given that we've got such deep-seated problems?
So I think we need to actually focus on the fact that there has been a record investment in alcohol and drugs, and that the level of investment, as the Auditor General also notes, has doubled. And we have, despite, as you will all recognise, some extremely challenging financial circumstances, we have maintained the investment in alcohol and drug partnerships at 112 million, and that we have also sought progressively to actually mainstream and baseline that money in order to give that security of funding going forward, so against an extremely challenging financial backdrop.
Okay, I've got a couple of other areas I want to just ask about quickly. Minimum unit pricing. You've mentioned that already. Caroline, in your letter to the Auditor General, you have repeatedly called this policy world-leading. You say it saved hundreds of lives. What's the evidence for that?
well, the evidence was provided by our colleagues at Public Health Scotland, so I'll ask Scott to speak to that one.
Yeah, so I guess the evaluation that we did on minimum unit pricing looked at a range of factors that looked at the impact of minimum unit pricing across Scotland, and within that we did highlight the impact it had on hospital admissions and reducing deaths. So really key, kind of, I guess, success factors from minimum unit pricing. And as I've commented before, you know, that our I guess summary from that report was that minimum unit pricing had been a success, and that we were supportive of the increase in minimum unit pricing that came in earlier this year.
But how are you able to link the two? How is that possible?
So in terms
how
of...
can you link minimum unit pricing to admissions to hospital?
Yeah, so one of the things that the report did, and we have a team of evaluators in Public Health Scotland who looked into this, is to do baseline comparisons with other countries. And within the report, we were able to kind of showcase the impact or the changes in trends that occurred in Scotland compared to England and other parts of the UK who hadn't introduced minimum unit pricing, as well as other literature reviews that were undertaken by the team when they were doing that. So there's a lot of data contained in our evaluation which showcases that our view was that MUP had had an impact in Scotland.
And how far do you think it should go? I mean, how far? Should we just keep increasing the price of drink in Scotland year on year?
So I think the important point that our report highlighted was the initial 50 pence had stayed static, but inflation had obviously increased over that time. So I guess in real terms, that 50 pence from when it was first introduced to the point it was changed to 65p actually was in effect a decrease. So there's definitely something about ensuring that we kind of track, I guess, the inflationary rates that happen in the country, and in effect that's what led to the change to the 65 pence.
It's just at some point we have this divergence between Scotland and England. People start to react to that. In fact, I read at the weekend, it was in the Sunday Post, that you are getting what used to be called booze runs. So people who lived on the south coast were hopping across the channel to stock up on cheaper drink, and now that appears to be happening in Scotland, certainly in the south of Scotland. People driving across to Carlisle and filling their boots and driving back.
So I think we need to be, I guess, careful of anecdote around those types of stories. No, I don't doubt that some individuals will be doing that, but the Public Health Scotland report did look into that, and I don't think it was as strong as perhaps has been suggested here. And I think an important part of any evaluation is that we continue to evaluate as time progresses. So obviously with the increase to 65 pence, it'll be important that we keep monitoring the key indicators like hospital admissions, deaths, and other harms related to alcohol.
Okay, I've just got one other area that just... Sorry?
One other brief question.
Very brief, Convener, very brief. Caroline, in your letter you list a number of stakeholders that you are liaising with. Scottish Health Action on Alcohol Problems, Alcohol Focus Scotland, and the Scottish Alcohol Counselling Consortium. It just struck me from that list that there's nobody there who's actually involved in the drinks sector. People like the Scottish Beer and Pubs Association, for example, that's just one. I just wonder whether you take advice also from people who are actually involved in serving the public.
Yeah, so we also work closely within Scottish Government with our colleagues in DG Economy, and work with them around. So there's been a lot of work with them around the discussion of and the work that Public Health Scotland are doing around alcohol marketing, for example. So yeah, we do engage through DG Economy with other stakeholders as well.
Okay, thanks, Convener.
Okay, thanks, Graham, for your forbearance. I want to now invite the Deputy Convener, Jamie Green, to put a final suite of questions to you. Jamie.
Thank you. Convener. I'm not sure the questions will be sweet, but they are a suite of questions. Thank you very much for your evidence given. I've been listening with great intent. Where do I start? Ms Lamb, let me put this in context. This coming Sunday, it will be 22 years since I lost my dad to drugs and alcohol. I was 22 years of age at the time, and he was 42 years of age. So I am now 2 years older than he was when he succumbed to these diseases. So I guess you might appreciate my sense of sadness, frustration, perhaps even anger that we're having this conversation 2 decades later. Because what I went through as a young boy, far too many people in Scotland are still going through. And all the statistics we've talked about today, behind every one of those statistics is a person. And year on year, more and more people are dying of drugs and alcohol in Scotland. 2 decades on from when I thought things could not get any worse. So I guess what I'm asking is, do you understand why so many people are so frustrated and so angry at the direction of travel with these statistics? Do you understand why so many people have lost confidence in the Scottish Government and your ability to manage this problem?
So, first of all, I'd say that I am very sorry for the experience that you went through. And as I think we've already recognised, the level of deaths from drugs and indeed alcohol is unacceptably high in Scotland. We do work very closely with families, with stakeholders, with people with lived experience. So yes, I'm sure Maggie can expand on that, but absolutely we understand the level of grief, of frustration and indeed anger around the many people who have been personally impacted by losing loved ones, and indeed by the stresses and strains of living in situations where people are affected by drugs and alcohol abuse. So I think we absolutely understand that. Maggie, do you want to say anything more to that?
I would just echo what you've said there. I think we have one of the cross-cutting themes of the National Mission is putting lived experience at the heart, and we've seen that through work like with the National Collaborative, taking that human rights-based approach, which has been very much co-produced with people with lived and living experience, but also across everything that we do. We make sure that we're listening to the voice of lived and living experience and work closely with organisations, particularly organisations like SFAD, Scottish Families Affected by Alcohol and Drugs, that do tremendous work in terms of supporting families and bereaved families as well in what is impossibly difficult times for them. So, yeah, I absolutely accept that.
Yeah, and it is impossible. It's particularly difficult if you're young, and many young people are living through this experience of being the carer for their parents who are struggling with alcohol and drug problems. And that is indescribable, to put it lightly. I had the unfortunate experience of having to repeat that situation a couple of years ago with another close member of the family. So more recently, gone through all of the experiences that we've talked about today, everything from the ADPs to the rehab options to the primary care options, and I can tell you firsthand, and I'm not saying this this isn't a point-scoring speech. I can say this from first-hand experience. It was incredibly difficult and nigh impossible to get support for someone who was struggling with an alcohol addiction, and that's just a couple of years ago in modern-day Scotland, and that's years and years after my last experience of that. So I personally do not think things are getting better, and I think many people watching this will share that view, unfortunately. But here's what I don't understand, and I appreciate all the money that's been pumped into this. You talked at great length about the doubling of the budget from 2013 to 2023-24, from 70 million to 160 million, to the ring-fence money for ADPs and the National Mission cash that's gone into all this. And I've heard a lot about that, and it's all very welcome. I mean, it really is. But yet, year on year, the numbers are still going up. The drug deaths were 527 in 2013, and in 2023 there were 1,172. So it seems like cash isn't solving the problem. we can keep pumping money into it, but the statistics are still heading in the wrong direction. And I can't get my head around this. Please help me to understand why pumping more money into it is not solve the problem.
So I think, first of all, that this is a problem that is, as Maggie, I think, has explained extremely eloquently, is extremely complex and also a very long-standing issue. And whilst I think, and I hope you will have heard from the evidence that certainly my colleagues have given today, just the commitment and the drive towards improving things. So whilst people are working incredibly hard, not in Scottish Government, in Public Health Scotland, but across all our alcohol and drug partnerships as well, this is going to take some time to turn around. Yes, we are investing. I think as I've said already, we've invested very much in trying to set the foundations to be able to have increased pace of delivery, but also to be able to sustain that delivery. But this is an ingrained problem, and some of the actions that we're taking are more effective in the short term. So the increase in residential rehab placements would be an example of that. Other things around stigma are going to take longer to absolutely mainstream into our society and into attitudes, and therefore create the conditions to really accelerate success in this area.
I mean, this phrase, I've heard the two phrases used a lot this morning. One is it's complicated, the other one is complex. Yeah. And I don't disagree with you. There's so many intertwining issues that make this complicated, that these are long-standing, generational problems, in communities like the ones I grew up in. And I understand and appreciate that. And there are so many wider macroeconomic factors that have been affecting this over the years that are outside of your control. But by saying it's complicated and complex doesn't fill me with confidence that we're heading in the right direction. What I wanted to do this morning, and I came in here with an open mind, is to leave this evidence session full of confidence that the problem is understood, that there's a strategy, there's a direction of travel which will take us in the right direction, and some honesty around any failures that have happened today. Now, I've heard some responses which do fill me with some confidence in that respect, and others which do not. And I guess this is your opportunity. This is your opportunity to say to people, yes, it might be complicated and complex, but it's always been complicated and complex. It was complicated and complex 20 years ago. That hasn't changed.
Yeah, and I think that we do have a strategy. We are taking work forward that is absolutely evidence-based, drawing not only on our own data and our own understanding, but also on what we know works from other countries and international evidence. We are also, at the same time, tackling the changing nature, not just of the different age groups but also that change in the use of drugs, but also changing the availability of drugs as well. And so also, very conscious about the impact of synthetics and what we need to do to make sure that we're not only using our early alert systems to alert us to issues there, but to be ready to respond. I was at the round table that Maggie referred to earlier this year, and hearing about the work they'd done in Dublin was and Cork was really, really helpful in that area. So we are seeking to learn all the time and to adapt our approaches as we go. Does anybody want to add to that?
No. Just support that.
Yeah. Can I ask a very specific question? Are you as nervous as I am that we are on the precipice of a major problem with fentanyl in Scotland? We've seen what's happening in other countries. If that arrives on our doorsteps, if the serious organised criminal gangs find a cheap and easy pathway to get that drug onto our streets, then we're not going to be talking about 1,100 people dying. We'll be talking about 10 or 11,000 people dying of drugs in Scotland.
Yeah, so that is exactly why we convened the round table. I think was it January last year? It was early in this year. Sorry, we're still in 2024. Early in 2024, which was absolutely about recognising the risks that we are facing currently, and seeking to learn from countries that are already in the throes of that experience as well. So, yes, I do think that there is a huge risk there. We are, I think, trying to do as much as we can to make sure that we are ready for that and learning from other countries' experience. But Maggie, do you want to add to that?
Yeah, just to add briefly, I mean, I think, yes, that it's a very real risk, and that's why we've stepped up radar. We've stepped up the incident management team for public health leads across the country. We have guidance out now for if there is an incident where we have a new or novel synthetic opiate coming in. But just to add to that, I think what we're seeing here in terms of drug trends is not fentanyl, but we're seeing nitazines or nitazines, which are actually more potent than fentanyl. We seem to have, in Europe anyway, it seems to have kind of skipped over. I mean, absolutely, we've been vigilant for fentanyl for many years now. These are of huge concern. The radar report, which publishes a quarterly report that goes out to the sector and details what we're seeing, but in terms of, it's also a very active process with radar. So if there's alerts that come up in between, or if they see any of their indicators that look like they have, of concern, then they will pick that up with local areas and feed that data out to the people that need to know that to manage that response and manage it responsibly as well, because it's very delicate information in terms of managing it and interpreting it. But yes, I think it is a big concern, but it adds to that dynamic of this other driver that we're seeing for the increased drug harms, which is the increased dynamism of the drug market. We're seeing more and newer and stronger synthetic drugs coming out. So over the last decade, we've seen lots of new ones. So I talked about the new sort of street benzodiazepine. So we had Atizolam, and then it was then replaced by Bermazolam, and then we see new ones coming out all the time. So it is a massive challenge in that regard as well. But it's something that we're very aware of and working really hard to address.
Yeah, and this comes on to the point that was discussed earlier about minimum unit pricing. I mean, look, I'm open-minded to doing whatever we can to tackle Scotland's drug and death problem. I hope you appreciate my earnest approach to that. However, I wasn't entirely convinced by the academic research that's been undertaken that makes the link. I want there to be a link. I want the policy to be a success if that is the policy. But you also need to be clear that there is evidence which makes the link. Now, the evidence that I have is by going and speaking to users, speaking to alcoholics, speaking to drug users. And I can tell you that many of them, when the cost of alcohol went way above what they can afford, simply moved on to street drugs. And there's so many people out there that will tell you the truth about that situation. And that's me not trying to politicise the matter because I have a problem with the policy. It's just from the anecdotal conversations that I've had with many of the support groups in the third sector, they're actually helping people on the ground. And I hope you're open-minded to that piece of work as well, because real feedback from real users is what matters, not just spreadsheets and statistics plucked out of NHS health boards.
No, I would totally agree. And, as you said earlier, there are people behind all the statistics. So, no, I'm very, very attuned to that. And I think what you've highlighted is, I guess, in the anecdote, you've got consequences of a particular policy. But, I think it's really, really important, though, that we don't then move to some way to discrediting the policy, because the policy is having an impact and evidence shows that. But I think it's really, really important that that type of feedback feeds into the work that we're all doing day in, day out. And I think just on the point that was raised earlier about radar, I think one of the things that's really key in Scotland is that we have that early warning surveillance system in place, which should give the committee comfort and confidence that when new drugs are emerging, that we have the mechanisms in place for alerting the country to that happening.
Yeah, and obviously the Police Scotland have a massive role in this as well to play. But I can't let the session pass without raising the correspondence that the committee has received from a joint letter from Alcohol Focus Scotland and SHAP, two organisations for which many MSPs will have a huge amount of time and respect for. Perhaps not all agree on every issue, but that's not the point. It's a very short letter, but it's a very, I'm afraid, quite a stark and critical letter. They simply want us to ask you to respond to their letter. And they do welcome many of the measures that you're taking. I don't think there's any doubt about that. But in their own words, it is their view that this is an inadequate, piecemeal approach and that the actions do not add up to a coordinated plan to respond to the public health emergency. They go on to say, we would be interested to hear views from the panel today as to how the actions listed in your letter, Ms Lamb, including the real terms cut to the alcohol and drugs policy budget, square with comments and recommendations made by the Auditor General. Here's your opportunity to respond.
Okay, thank you very much for that. And I sort of covered some of this through the evidence session, but I think the first thing I would say is that a lot of the work that we have been doing has, given that the alcohol and drug partnerships are involved in providing services to people affected by both alcohol and drug abuse. A lot of the actions that we've been taken are absolutely aimed at supporting people regardless of the type of substance that they're challenged with. So in terms of the increase in residential rehab, around a third of those places are used by people who have alcohol abuse problems, about a further third of people who have both drugs and alcohol abuse problems. There's the work around stigma is absolutely relevant, regardless of what type of nature of your problem. The work around the workforce, so our workforce action plan. The work that Maggie described earlier around the mental health and aimed at ensuring that mental health services are working more closely with alcohol and drug partnership services, and indeed the support for families. So there is a lot of work that we're doing that's absolutely relevant. And in terms of the national specification that we're developing and expect to publish next year, that is a national specification for drugs and alcohol services. We have also been working on a UK-wide basis on the development of clinical guidelines for the treatment of alcohol problems, which is aimed at absolutely at ensuring that those treatment principles are on an equal set-up basis with those relating to drugs.
Are you going to be able to achieve all of that on a real terms budget cut? So
I think again, to come back to my earlier response, we need to focus on the fact that budget has been doubled, and that we have, in the face of very significant financial pressures, maintain the budget. We will be allocating 112 million to alcohol and drug partnerships, and we are also seeking to ensure that they have stability and assurance of that money going forward, because we know that having that security about funding is really important in terms of them being able to spend it well. So we've been working to increasingly baseline that funding as well. And the final,
you must be looking. You must be sitting around the table with the Cabinet Secretary for Health or the Finance Secretary and saying we need more money. It's simple as that. I mean, I hope you can give me some reassurance that you're jumping up and down asking for more money, because you know that that's what it takes to deliver improvements. We can't settle for a real terms cut, I don't think.
So absolutely. I have, in my role as accountable officer, I have to look across a range of pressures across the budget, but I also have to be realistic about the level of funding in total that the Scottish Government has available to it, and the need to invest in other portfolios as well. And I think the final point I'd make here is the publication of the Population Health Framework next year, because actually, a lot of what we need to do here is to address the underlying causes of poor health, including poor health that is related to alcohol and drug issues, and the socio-economic factors that drive that. So that is absolutely a cross-government approach, and as I described earlier, a cross-society approach.
And I'm glad that that's focus as well. I guess we're running out of time. So there was one other appendix to the Auditor General's report which really strikes me, and I think I perhaps raised it with the Auditor General when he gave evidence, and that's Exhibit 4 around barriers to access of services. Now, this table really talks you through the journey from identifying that you have a problem through to getting treatment and then being supported post-treatment. It really talks you through that journey. But what it does do instead, I think, is paint a very dim view on the many barriers that exist as you go through that process. And it's the same issues that come up time after time. It's the being unaware of where to get help, being people being unavailable to provide it, the waiting lists, the shortages of suitable staff, the high eligibility criteria that Mr. Dornan mentioned earlier. And then once you get into services, it's finding a service that works for you, and everyone is different, every situation is unique. And coming out of that, being able to sustain that sobriety or abstinence from substances. But it seems to me like it feels like the whole system is stacked against you. I mean, and as I said, anecdotally, it's incredibly difficult to navigate it.
So I would accept that our services need to be more joined up and easier to navigate. So Maggie spoke earlier about the National Rights Charter.
National Collaborative Charter.
Collaborative Charter that was published just earlier this week, and that's about helping people to understand what their rights are. But it also points to the importance of having people with lived experience, not just at the heart of the national work that we're taking forward, but also engaged at a local level in their alcohol and drugs partnerships. And I think our latest reports show that I think all of our alcohol and drug partnerships now are including people with lived experience who are absolutely the best people to be able to provide that, real lived experience of what it's like trying to access services in a way that helps local services to improve the way in which they're working as services, but also collaboratively with other services to make it as easy as possible and to ensure that any stigma has been taken out of that process.
Yeah, I mean, that only works if the services are there. I mean, the reality is you get very limited time with your GP when you speak about these issues. You really need services that are as close to people as you can get them in their own communities. And the reality is, I'm afraid, over the last decade, is so many of those services have simply disappeared due to funding issues. And I think that's a real source of shame, unfortunately. And that's resulted in many regional disparities. If you look at my own region, the West region, it paints a picture of postcode lotteries on outcomes. So Inverclyde, North Ayrshire, in my West region, outside of Glasgow and Dundee, are numbers 3 and 4 in terms of the per capita drug death rate. If you look at East Renfrewshire and East Dumbarton, they're at the bottom of the league table. And the difference is huge. It's 7 or 11 per 100,000 at the bottom of the table, and it's 33 and 37 per 100,000 at the top. It's a huge difference. The life expectancy is massively different in those areas too. And there are stones throw away from each other. That doesn't make sense. What is going wrong?
Yeah, so absolutely. I think we recognise that there is variation, and as Maggie's already described, and as we know from the drugs death statistics, a lot of that is driven by underlying rates of poverty in those areas. So that's the core cause that we need to be working across government and across society to address.
Okay, thank you, Convener. Appreciate your time.
Okay, thank you very much indeed. I'm bound to observe on that last point, it's not just about poverty, apparently, is it? It's about inequality. And that's something as a Parliament perhaps we should spend a bit of time looking at in a bit more depth. But can I draw this morning's evidence session to a close, and can I thank each of you for the answers that you've given to our wide-ranging questions. So on behalf of the committee, can I thank Scott Heald for your evidence from Public Health Scotland. Maggie Page in particular, can I thank you for answering the questions that we've been putting to you on behalf of the Drug Strategy Unit, and to Chief Executive of the National Health Service, Director General Health and Social Care, Caroline Lamb, the Accountable Officer. Can I thank you too for appearing before us and helping to answer the questions that we've posed. I'm now going to move the committee into private session and draw the public part of our meeting this morning to a close. Thank you.